started from like top level it is started,
Right.
and from a few hospital also it is started. Like
Who
because
is
most of the
majorly
like ID and even Dr. Atul Patel started from Ahmedabad, and Dr. Vinay Kulkarni started from Mumbai also. Dr. Gilada started, Dr. Maniar
right,
started. So
right.
those who are like case to case basis they are starting, and not for all the patients, but selected patient they are starting. So
Price
those
date? How
patients,
much?
sorry,
Price date?
so
Price.
2,600 will be there.
2 6. Okay.
Yeah. So that too we are giving like a backbone free also.
No, Vivek, the price is 2,300
Yeah,
with any of the backbone free.
backbone also.
Abacavir, Lamivudine, or
Gotcha.
Tenofovir,
Gotcha.
Yeah,
Tizidabine, or TAF, and
I
Tizidabine, or
think,
even DDG also, sir.
okay. So I think that's what TAF and FTC separate and then Doraverin separate. We should give the two please.
Yes, sir.
yes.
Yes, sir.
Right. Right.
Initially, DCG allows only the single, sir. Once we launch it, then we have to work on the combination, sir.
Single pill again. I mean, combining it and that.
Yes,
Yeah.
sir.
And Lenacapavir by this year end?
Yeah, it is expected, sir.
Most probably, sir.
Most probably.
Nandakishore, are we live?
Uh, just 10 seconds, sir.
Yeah, yeah.
We are live, sir.
Okay, wait for like we will start sharp at 7:30. 1 minute to go. Dr. Ketan, we can start.
Yeah, thank you. Okay. Okay, so thank you everyone for joining. I'm Dr. Ketan Kulkarni from the Medical Services team at MCure Pharmaceuticals Limited. So on behalf of MCure team, we welcome you for today's webinar. So today's webinar is on HIV updates, that is the newer updates in HIV treatment and lessons from interesting cases. So we have two speakers today, Dr. Santosh Gattu sir, as well as Dr. Ravi Teja sir. So to introduce Dr. Santosh Gattu sir, sir is a FMB infectious diseases. He's an infectious disease consultant and specialist at Continental Hospitals, Hyderabad. Sir has published multiple peer-reviewed research papers in infectious diseases and as well as the COVID-19 pandemic. So he has presented his research at the international conference ECCMID at Barcelona and ID Week at Boston. Sir has secured all India rank 2 in the FNB fellowship entrance examination. He has received a distinction in DNB internal medicine practical examinations, and his areas of interest include many topics like antimicrobial resistance, multi-drug resistant infections, transplant and immunocompromised host infections, fungal infections, critical care, tropical infectious disease, and of course, the HIV and opportunistic infections, along with the antimicrobial stewardship. Our second speaker for today is Dr. Ravi Teja sir. So his topic is ART alone sufficient? Lessons from interesting HIV cases. Sir is also an infectious diseases consultant with FMB in infectious diseases. He has also received the the top med certification from USA. So sir is an infectious disease consultant and specialist at KIMS Hospital, Hyderabad. He has around 15 publications. He has also received the ECC MID travel grant for 2024. And he is also a CIDS trainee. He has received the CIDS Trainee Research Award in 2024, and his areas of interest include infections in immunocompromised hosts, tropical and fungal infections, and adult vaccination and AMS. So with this introduction, I will like to invite our first speaker of today, Dr. Santosh Rattu sir, to enlighten us about the newer updates in HIV treatment. I am stopping the sharing. Over to you, Dr. Santosh sir. Sir, you can unmute.
So thank you, Ketan, for that introduction. So good evening, everyone. I'll be talking on latest advances in HIV treatment. So I'll be focusing more on the recent updates in the last 3 to 4 years, where we are kind of getting transformed in HIV treatment from the current standard single fixed dose combination to the newer regimes. So what's new exactly in HIV treatment? So HIV treatment is currently progressing into various simplified two-drug regimes, unlike a single pill, three drugs combinations regimes or long-acting injectables. So we actually need more long-acting drugs which are being preferred to reduce the daily pill burden. And more so, there is this concept which is being more discussed and important in HIV is in terms of metabolic syndrome, because HIV is not just getting your viral load suppressed and picking up your CD4 counts. So many right now, a lot of direction which is moving in this concept of metabolic syndrome. So we need drugs which are lipid friendly and which are weight neutral and which actually have less adverse effects, because we are dealing with more of a metabolic syndrome kind of concept. So what are the current existing standard of care treatments and what are the pros and cons if we kind of think in this aspect? So we know that TDF, 3TC and DTG, or TAF, FTC and DTG are the current single pill fixed drug combinations. So the advantages, yes, it's a single pill one. Because of the INSTI thing, we have a high genetic barrier for resistance, and there are hardly any drug-drug interactions, unlike any other PIs. But the problem which these regime has is in terms of renal toxicity, and certainly in type 2 renal tubular acidosis, which we see more with TDF. Second, because of the bone mineral density loss, especially in elderly people who have a lot of comorbidities, they are at risk of these osteoporotic fractures. And of course, when you have TAF and DTG in combination, we are worried about weight gain and dyslipidemia, because when you have weight gain and dyslipidemia, they are at risk of obesity and high atherosclerotic cardiovascular events. So, can we have a pill which has a similar efficacy with the current existing standard regimes, and can it bypass the adverse effects, or will it be more convenient? So let's look into that. So before my talk, I'll probably give three patient profiles which generally come to us in our day-to-day clinical practice. So what would be the appropriate ART regime when you see such three different patient profiles? So patient number one, these are the common patients who are young males, no comorbidities, who have normal BMI and who have normal renal status. So the ART regime here we choose is one. So patient number two is an elderly female who is a diabetic, had a recent cardiovascular event, and who has a creat of 1.3. So there the ART regime would shift. And of course, patient number three, where certainly they keep asking us in our OPD saying that we are done with taking everyday pill. So can we get rid of this? So do we have any long-term injections or do we have any long-term oral pills? So these are the three different patient profiles. So let's see, can we match anything in terms of newer drugs in these different patient profiles? So I'll start with these drugs, cabotegravir and rilpivirine. We know cabotegravir and rilpivirine is the first long-acting injectable ART that has actually transformed the HIV treatment, both treatment and prevention, by replacing the daily oral therapy with either a monthly or bi-monthly injections. So we know cabotegravir is an INSTI, rilpivirine is an NNRTI. So they generally come as 200 mg and 300 mg of cabotegravir and rilpivirine. It depends on monthly or bi-monthly, the dose differs. And of course, it's an INSTI and an NRTA, so you should avoid with CYP3A inducers because in India we have a lot of TB burden, especially they'll be on rifampicin. So what is the data which is actually supporting cabotegravir and rilpivirine? Because we know we had Atlas 1, Atlas 2, and other many trials which actually supported cabotegravir and rilpivirine when we shift these patients as a long-term maintenance therapy. So this was the recent Latitude trial which was published in NEJM 2026, where in the US, at least there was a significant problem with ART compliance because they have to take everyday pill. So when the compliance is an issue, so the overall virological failure is high. So in the Latitude trial, it was a phase 3 randomized control trial which was done in US. So they actually shift the patient in two arms. The one arm received the standard care, irrespective of whatever HIV regime they are on, and the other arm was receiving cabotegravir and rilpivirine. So if you see the treatment failure in cabotegravir and rilpivirine arm, it was actually very less compared to the standard of care. So this is because they have these patient groups were having issues with the compliance. So once they were shifted from daily pill to once monthly or bi-monthly injection, so naturally their virological suppression would be high compared to the standard of care. So there was superior HIV-1 treatment efficacy with monthly long-acting cabotegravir plus rilpivirine, especially in subgroups where you have adherence challenges. So second, this was one more recent trial, SOLAR trial. So this was published in Lancet 2025. So here the idea is whether if the patients who are on TAF, FTC, and dolutegravir or bictegravir, and when they are nicely virologically suppressed for more than 6 months, can we shift them to once monthly or once in 2 months cabotegravir rilpivirine injection? That's the idea behind this SOLAR trial. So again, this was a phase 3 randomized control trial where one arm was receiving standard TAF, FTC, and bictegravir, and the other arm was receiving cabotegravir and rilpivirine monthly injections. So naturally, the primary endpoints was week 48 virological suppression, and secondary endpoints were in terms of safety, patient preference, and patient satisfaction. So at week 48, the biological suppression was more or less equal in both the arms, and cabotegravir rilpivirine switch from the daily oral pill was found non-inferior to the standard of care. And in fact, there were good retention of patients in terms of compliance and more satisfaction from the treatment satisfaction from the patient standpoint because they don't have a burden or anxiety of taking daily pill and their overall compliance actually went good. Except 3 patients in the cabotegravir rilpivirine arm had treatment failure. 1 patient had non-compliance, and 2 patients out of 400 odd population had treatment emergent resistant mutations. Because we know rilpivirine is an NNRTI, it technically has little lower genetic barrier of resistance. So there can be a little component of treatment emergent resistant mutation, especially to rilpivirine drug. So third is actually this trial is ongoing. Unlike virologically suppressed patients, Crown trial is actually recruiting patients which are treatment naive, irrespective of virological suppression or irrespective of their initial viral loads. can we directly start them on cabotegravir and rilpivirine is what they're actually looking into. So probably in 2028, we will these results of Crown trial will be out, so we can look into that. So what are the current guideline recommendations for cabotegravir and rilpivirine? So as per the DHHS, patients should be virologically suppressed for at least 3 to 6 months, and there is no documented or suspected resistance for cabotegravir or rilpivirine, and there shouldn't be any prior virological failure on any ART regimes. And of course, we are not using any TAF component here, so there's no coexisting hepatitis B. So from the WHO, it recommends as a long-term injectable version, mainly for the PrEP. Still, it hasn't come into the guideline in WHO for the treatment utility. But of course, in the US, probably in the last 3-4 years, they're using it in a nice virologically suppressed patients. So moving on to the next new drug, which is doravirine. So doravirine is a modern HIV-1 treatment because it's an NNRTI, so it's mainly used for the HIV-1. It was approved by FDA in 2018, which should be taken daily once pill and often combined with the other standard backbones. So it's an NNRTI offering good tolerability and less drug-drug interactions, unlike efavirenz and nevirapine, which are the older NNRTIs. So usual common adverse effects of dizziness, headache, and fatigue and nausea were reported, although very less compared to the traditional efavirenz toxicity. So this was the one Emcure has launched doravirine probably 3 months back under the name of Hofix. So doravirine comes as 100 mg pill separately. So we need to basically combine doravirine to the standard TAF FTC or TDF 3TC backbone. And again, it's contraindicated with the CYP3A inducers, especially with rifampicin in India, because it's an NNRTI. So, but compared to boosted PIs and INSTI, still it has a low resistant barrier compared to boosted PI and INSTIs. So let's look more into the data and the recommendations where doravirine can be placed. So doravirine positioning as per the guidelines, DHHS says it is classified as an alternative regimen. Still, the US guidelines would prefer TAF, FTC, and DTG or Biktarvy as the first line regime. And doravirine can be placed as an alternative regime in as per US guidelines. But in the European EACS guidelines, it is actually recommended as a first line regime, simultaneously in place with the second generation INSTIs. So generally, the backbone is same, be it TAF or FTC or TDF or 3TC. The third drug would actually make the difference. So whether the third drug is a DTG or whether the third drug is doravirine or the third drug is a PI. So that's where the whole game would differ. So when you see PIs generally has good lot of drug-drug interactions and dyslipidemia, where doravirine would offer an advantage in that space. And DTG, of course, it has a high genetic barrier for resistance, but it can cause rapid weight gain and dyslipidemia. So we can select a specific niche population where you can use the similar backbone of TAF and FTC. And then if you're facing issues with rapid weight gain and dyslipidemia in your patient, especially in elderly who have higher atherosclerotic cardiovascular risk, maybe that's one area where we can substitute DTG with doravirine and C. So what is the data backup for doravirine? So Drive Forward was one of the early trial where doravirine was compared head-on-head with darunavir and ritonavir. So because we know darunavir, ritonavir has a good genetic barrier for resistance, so it's a very potent drug. So whether doravirine is non-inferior to darunavir, ritonavir in terms of potency actually looked in. So this was a phase 3 randomized controlled trial where doravirine was compared with darunavir and ritonavir. So the primary endpoint at week 48, the virological suppression was more or less equal in both the arms, and the median CD4 rise was also comparable in both the arms. So in terms of safety and tolerability, we know darunavir, ritonavir has drug-drug interactions and not lipid friendly. So that's where doravirine would replace the space. So even the long-term outcomes, the 96-week and 144-week data, the virological suppression was in par with darunavir, ritonavir. So moving to the next trial, probably the drive ahead trial, where when your patients are on, of course, we are not using this efavirenz based regime because they wanted to compare efavirenz based regime as a standard arm. So in the treatment naive patients in HIV-1, they compared the backbone is same. One arm was receiving efavirenz, the other arm was receiving doravirine. Again, the virological suppression and the virological response and CD4 count increase was comparable in both the arms. And we know definitely doravirine doesn't have these neuropsychiatric effects and it's lipid friendly compared to efavirenz. So moving to the third drug, islatravir, because islatravir is it's a different or a novel class ART, unlike the current existing ART drugs. So it represents a novel class called nucleoside reverse transcriptase translocation inhibitors. It's an NRTTI, which is a newer class of ART, where it actually inhibits the reverse transcriptase by preventing the translocation of the enzyme. So if you can see this picture, so once the virus attacks and undergoes an endocytosis, here once the reverse transcriptase enzyme is being synthesized, so it actually prevents the translocation of the enzyme and integration. So that's where the islatravir would actually have a role. So designed to block HIV replication with high potency. So one advantage with islatravir is it's a very high potent drug and it has a nice long intracellular half-life. So it's been studied as an everyday oral tablet or once weekly oral tablet, or even they're looking in terms of long-acting subcutaneous implants, mainly for the PrEPs. So half-life, because of the long intracellular half-life, you can use this drug as weekly oral tablet or monthly subcutaneous form. Safety, though the initial trials used higher dose of islatravir, which led to lymphocyte reductions and in turn CD4 counts reduction. But in the newer trial, this adverse effect was actually taken off because the dose was appropriately adjusted where these lymphocytes were not much affected. So if you see the development in islatravir in the individual monotherapy trials, it showed rapid virological reduction in treatment naive patients and in combined studies. Actually, this is the space where doravirine and islatravir combination is being looked up. So doravirine and islatravir has been studied as a once daily fixed dose regime for HIV-1, where it showed strong efficacy and tolerability, be it treatment naive patients or be it virologically suppressed in both the subsets. So let's go into the data which actually supported islatravir and doravirine combination. So this was published in Lancet HIV 2024. So when you actually shift the patients who are nicely virologically suppressed, irrespective of a standard backbone and probably a DTG arm, when they are nicely suppressed with these three drugs, so can we shift the patients to islatravir and doravirine and with maintaining a good virological suppression? That's where the idea of this trial. So doravirine and islatravir have complementary mechanism of actions and resistant profiles. So when you switch from three drugs to a two drugs, you're actually reducing the drug burdens and the long-term toxicities, which we generally see with TAF or TDF. And also you can have minimal drug-drug interaction. So in the previous studies, they used doravirine of 100 and islatravir of 0.75 mg. At that time, there was reduction in CD4 cells and the total lymphocyte count. So now that a fixed dose of doravirine 100 and islatravir at 0.25 mg was found to be non-inferior when compared to the standard TAF, FTZ, and Biktarvy, where the virological suppression at 48 weeks and in turn the long-term efficacy at 96 weeks was also being studied. So this was a study design where They have enrolled the patients who are virologically suppressed for at least 6 months and no prior documented virological failure or documented mutations to either doravirine or islatravir. So they eliminated patients whose viral loads were more than 500 and there's documented resistance to doravirine and of course active hepatitis B. So if you see in one arm, they were on TAF, FTC, and Biktarvy, and the other arm were receiving doravirine and islatravir. So at 48 week, the virological suppression that is less than 50 copies were the cutoff. So doravirine and islatravir combination was found to be non-inferior compared to our standard regime. So this slide I borrowed from the recent CROI update. So in this trial, there were two treatment emergent resistance for the doravirine and islatravir combination. So predominantly, if you see, there were M184I and M184V, which are mainly for the doravirine, which are the NNRTIs. So in conclusion, in treatment-naive people with HIV, efficacy of initial treatment with doravirine and islatravir was found to be non-inferior compared to your standard drugs. And more or less, the HIV viral load suppression was comparable in both the arms. Less than 1% of the population had experienced treatment emergent resistance. And in terms of adverse effects, doravirine and islatravir were well tolerated. Of course, there's no Hep B activity, so 3 new Hep B infections were reported in the doravirine islatravir arm. So, what are the recommendations in this space with islatravir and doravirine combination? So, as per the DHHS, so if the patient is on a stable anti-ART regime and they're nicely biologically suppressed for at least 6 months, and there is no history of any biological failure in the past, and there is no documented resistance to doravirine. More importantly, it's not recommended for patients with an EGFR of less than 30 or whose weight is less than 40. So this can be the selection criteria where you can make a switch from a 3-drug regime to a standard maintenance islatravir and doravirine maintenance therapy. So in the European EACS recommendation, it actually recognizes or places this combination little higher because European guidelines typically they favor a simplified 2-drug regimes to reduce the long-term toxicity and the pill burden, where the patient will have multiple comorbidities and a lot of other pills which would add upon in terms of toxicities. So there were two major trials where doravirine and islatravir were actually compared. So this was which we were talking switch from Biktarvy, FTC, and TAF to doravirine and islatravir. So first one was you can initiate in HIV treatment naive patients, and the second trial, of course, once they are virologically suppressed, we can safely switch from the standard 3-drug regime to islatravir and doravirine. So moving to the fourth drug, lenacapavir. So we are hearing a lot of news in this space of lenacapavir, especially in terms of pre-exposure prophylaxis, where it's being marketed as HIV vaccine. So lenacapavir, it's a long-acting HIV capsid inhibitor. It got FDA nod in 2022. So FDA mainly approved it initially in the space of multi-drug resistant HIV-1 because there's a lot of data in this space where patients who are failing on different ART regimes, then once they were introduced on lenacapavir, they achieved a good virological suppression. And then in 2025, WHO approved it as a twice yearly injection for HIV prevention. Individuals who are sexually active can take a shot every 6 months as a PrEP medication as per the WHO. So it's a capsid inhibitor. It interferes the viral capsid assembly and the nuclear input. So it's the first HIV drug which can be given only every 6 months, either in treatment heavily experienced patients or in terms of prevention. Again, it comes as two forms, both as an oral form and a subcutaneous injectable form. And contraindication if a patient is on an active CYP3A inducer like rifampicin. And the Calibrate trial and the Capella trials are actually ongoing in this space with lenacapavir. So did we move from once daily pill to once weekly pill, which is actually a good thing for our patients, because many a times patients keep asking us, can we get rid of this daily pill? Can we shift to a once monthly pill or a once weekly pill? So how far are we to this once weekly oral pill? So the islatravir and lenacapavir combination is considered as one of the most newer exciting strategies in the HIV treatment, because once weekly islatravir and once weekly lenacapavir have actually shown good virological suppression compared to the once daily pill. So we'll go into that study in the subsequent slides. So here, islatravir, when you use it as a daily drug, the dose is 0.25 mg, while when it is given as once weekly, the dose is 2 mg. So these are the two landmark trials which actually led to this recommendation. So ISLAND 1 and ISLAND 2 are the standard trials. So both trials, what they have actually done was individuals who are biologically suppressed for at least 6 months, and can they be shifted, or can a switch can be made from once daily pill to once weekly pill with islatravir and lenacapavir is what they have actually looked into. So ISLAND 1 and ISLAND 2 both were randomized controlled trials. So in ISLAND 1, patients were receiving only Biktarvy, TAF, FTC, and Bictegravir. And in ISLAND 2, irrespective of any standard of care regime. And at week 48, which was a primary endpoint, they have looked into how many individuals were actually virologically suppressed. So the intervention was islatravir 2 mg plus lenacapavir 300 mg once weekly versus a standard once daily fixed combination pills. So there's a strict exclusion of the prior virological failure patients. So anyone with a documented history of virological failure on any prior HIV regime was excluded. And because a patient can be fully suppressed for at least 6 months, patient should be fully virologically suppressed for at least 6 months to qualify into this. And irrespective of any INSTI resistance, both are a novel or different class like islatravir and lenacapavir. So this wouldn't make much of problem. So these were the key results at week 48. The virological suppression was achieved more than 90% in both the arms. And of course, it was a non-inferiority trial to begin with. So it met the non-inferiority margin compared to the standard of care regime. And the CD4 were also stable across both the groups. So clinical implication, this is the first long-acting oral HIV regime, like once weekly oral HIV regime, where we can safely transition or switch our patients from once daily regime. Because the advantage is it will reduce the daily pill burden, it improves the convenience for the patients. So adherence and quality of life, moving from 365 pills a year to just 52 pills a year, would represent a good paradigm shift in HIV management. So moving back to my first slide, where we see these three different kinds of patients. So patient number one, who was a young male, who there's no comorbidities, normal BMI and renal status. So probably with the newer options which are not available, we typically put them on either TLD regime or an LD regime, which are the two drug regime. But if you include the newer drugs, we can actually put them on islatravir and doravirine, and also probably cabotegravir and rilpivirine maintenance drugs. So in the patient two, which we also see an elderly female, a lot of metabolic issues or dyslipidemia like diabetes, cardiovascular event with a borderline creatinine. So this is a space where we feel little uncomfortable because TAF or TDF, they have issues with toxicity. And if you combine TAF and DTG, the lipid profiles, weight gain, obesity, and the cardiovascular risk would go high. Probably this is one space where we can put them on islatravir and doravirine combination, or if they are virologically suppressed, we can put them on islatravir and lenacapavir once weekly pill. And of course, cabotegravir and rilpivirine once monthly or bi-monthly regime. And third patient, of course, irrespective of any BMI or comorbidities, if the patient is not willing to take any daily pills, the newer options are the answers for them, like islatravir and lenacapavir once weekly pill, or a monthly or once in 2 months shot of cabotegravir and rilpivirine. So the future directions, so majority of the newer drugs can be used, be it a long-acting injectable or a once weekly oral switch. So right now the data is more in terms of nicely virologically suppressed patients and making a switch from the current virologically suppressed patients to once weekly or long-acting injectables. Although new data is being explored in treatment-naive patients as well for the newer drugs. So shifting to two-drug ART regime than the standard three-drug combination things, moving more in terms of into a longer-acting drugs space rather than a daily pills. So combining more potent, longer-acting drugs to prevent cross-resistance, and of course, we need more lipid-friendly, weight-neutral drugs, which would actually lead to less complications of metabolic syndrome. Thank you.
Thank you, sir, for a very enlightening talk. Before we start the next session, I'll request the attendee doctors who are joined online. They can post the questions in the comment section in the webinar. So thank you, sir. Now I'll invite Dr. Ravi Teja, sir, to start his presentation.
Okay. Okay. I'm audible.
Yes, sir. You are audible.
Okay. So, good evening, everyone. So today's my topic is a few lessons from interesting cases of patients with HIV. So, yeah. So I'll just discuss two interesting cases which we have encountered recently. So, case one, he's a 48-year-old gentleman. He presented he's from Hyderabad. He came with chief complaints of was size 2 of new onset generalized seizures, 2 episodes of generalized seizures, 3 weeks prior to the admission. And coming to history of present illness, the generalized seizures, the first episode started while he was at home, while he was walking near at his home, and he regained consciousness within few minutes. And prior to the onset of seizures, he had headache and tiredness for 1 to 2 days. And there is also history of significant involuntary weight loss, but appetite was normal. There is no history of head trauma, no visual disturbances, no vomiting or diarrhea. There is no history of fever also. There is no history of travel. There is no history of upper limb or lower limb weakness or facial weakness. So, few days after the first episode of seizure, the patient admitted to a local hospital in Vijayawada due to generalized weakness, persistent headache. So they've admitted him. So after the admission, he suffered second episode of seizure in the hospital. And after the seizure, he was not in good sensorium, so he required ventilator support, and later tracheostomy was also done. So 5 days before admission at our hospital, he started to have high grade fever spikes, which were not there before. So after second episode of seizure, the sensorium is decreased. So hence he required ventilator support, and subsequently tracheostomy was also done. Past history: the patient is a known case of HIV for 5 years and is on government ART of dolutegravir, TDF, and 3TC. The history is taken from spouse. They've informed that he's compliant to his ART. And prior to admission, he also received methotrexate and oral steroids for about few months. The cause is was just mentioned as some joint pains, some polyarthralgia. Hence, he received methotrexate steroids locally. And he also had pulmonary TB 5 years at the time of diagnosis of HIV. He had pulmonary TB and he has completed treatment. No other comorbids, no other surgeries. And he's a farmer by occupation, and there are no addictions, no pets at home, and he stays with spouse at home. And so the initial assessment of the patient after initial his chief complaint history and is a presentation with acute headache with new onset generalized seizures and altered sensorium with significant weight loss in a patient with HIV. So we thought it is 2-3 weeks illness, so it can be subacute or more of subacute meningoencephalitis, which the causes might be tuberculosis, cryptococcus. The farmer by occupation, we also had a differential board. It can be myelioidosis, or it can be some commute-acquired meningitis, pneumococcal and HSV, or he did not have weakness of upper limbs or lower limbs, no cranial nerve weakness, but we thought some intracranial space occupying regions also have to be kept in mind, like toxoplasmosis, neurocystic sarcosis, brain abscess, and primary CNS lymphoma. And we thought this fever is new onset for last 5 days. It was not there at the beginning. So this new onset fever he developed after hospitalization locally. So we thought it might be some new hospital acquired infection, the cause of fever. So on admission, he was on tracheostomy support. He was on oxygenation with FI out of 40%, and the central line was there, which was removed on 1 day after admission. So there was system examination was normal. So we could not find any clinical clue on examination. So before coming to our hospital, only the patient underwent CSF because he had headache, he had seizures. So they also suspected a meningoencephalitis. So CSF was done before admission, which is showed 3 cells with lymphocytic prominent. Protein was 74 milligram per deciliter and glucose was 55. More or less SLR CSF could not help in finding an etiology, but MRI brain was done locally, so which reported scattered cortical brain lesions. And these are the initial labs in our hospital. Patient had mild anemia with neutrophilic leukocytosis. Creatinine was normal. There was mild elevation in AST and ALT. And paid blood cultures at our hospital, which reported 4/4 gram negative bacilli as expected, which we thought the fever is the reason of might be the reason of hospital acquired infection. And subsequently, the blood culture identified carbapenem resistant Klebsiella. So his CD4 count is 20 cells. His viral load is 5,000 copies. He's a HIV-2 patient, and we have repeated the CSF here in our hospital, which also did not give us any clue. There were 0 cells. Glucose was 112. Protein was 62. All the stains, all the cultures are negative. The gene export is negative. ME panel is negative. And the cryptococcal antigen on the CSF and toxoplasma PCR is also negative. So at this point, we were stuck in this patient, like what might be the cause of this scattered acute subacute meningoencephalitis with scattered cortical bilateral lesions on imaging in a HIV patient. So there was discussion of giving empiric ATT. So we have repeated MRI here. So as you can see, multiple small hyperintensities present both cortical and subcortical regions, and also in the deep areas also. So multiple lesions were present bilaterally, both cortical and subcortical regions, as you can see here, hyperintensities. So it's another section. So yeah, as you can see here, multiple hyperintensities, both cortical and subcortical regions. So at this point, so as is a HIV host, so we have pushed her for brain biopsy. So the MRI imaging showed diffuse scattered multiple focal enhancing lesions bilaterally distributed, both cortical and subcortical regions. So as you can see here, multiple lesions. So at this point, we are stuck in this patient whether to give empiric ADT or not, but CSF is normal. So we had final discussion and went ahead with brain biopsy. So this is a report showing multiple bilateral cortical and subcortical hyperintensity lesions, no meningeal enhancement. So image guided biopsy was done. So the tissue gene expert was negative, gram strain culture were negative. So this is the initial H&E stain of the brain biopsy. So is a low power image showing multiple small oval refractile structures. The high power image showing the oval structures, refractile structures on H&E stain. And AFB stain and modified AFB stain, both are positive. Pink oval structures, as you can see here. The PA stain and GMS stain also were positive. As you can see here, oval structures, multiple are there. So at this point, we had a lot of discussion. What is this? Whether it is some protozoal infection or some fungal infection, but AFB stain is positive. So we thought it can be some gastric protozoal pathogen. So we have sent for PCR for microsporidiosis, which was positive. Okay, so this is a case of CNS microsporidiosis. So sequencing is awaited on this sample. So there are many genus and species to this microsporidiosis. So that is awaited. So is a patient who is clinically unwell, virologically not suppressed, immunologically also not unwell, and also received methotrexate and steroids for unproven joint disease. So we thought that might be the cause of this disseminated disease in this patient. So a few slides about microsporia. Microsporia are obligate eukaryote intracellular pathogens. There are about 200 genera and 1500 species in this microsporia, and there can be molecular phylogeny. So RNA is being used nowadays to classify this 200 genera and species. So among the various genera and species, there are two main important genera, which are encephalotozoon and enterocytozoon. So these are the main two pathogenic organisms. So in immune deficient hosts like HIV, they present with diarrhea and wasting syndrome. That's the most commonly we see in HIV patients present with diarrhea, but it can also lead to disseminated disease in this patient. So what was interesting is this patient never had history of diarrhea. So that was an interesting point. And so this microsporidiosis can be, most commonly it is orally ingested, the pathogen, but at times inhalational routes are also described very rarely. So there are main two genus, enterocytozoon and encephalotozoon. So this encephalotozoon is the most common for dissemination, disseminated disease. So this encephalotozoon, there are three main species: Helium, Cuniculae, intestinalis. So these present with disseminated disease, but enterocytozoon genera present with gastrointestinal illness. So GI tract infections are the most common presentation. So enterocytozoon, there are two different species, intestinalis and bionuclei. So but in HIV patients, they can present with granulomatous hepatitis or sclerosing cholangitis also. Most commonly is associated with malabsorption because of decreased mucosal surface area and functional immaturity of villus epithelial cells. And CNS infection, as we discussed, encephalotozoon genera is most common cause of disseminated disease. It can also present as granulomatous encephalitis. And this infection has been recognized in patients with few patients, and which mimics toxoplasma as in our patient. multiple ring enhancing lesions, which there are multiple differential diagnoses in a HIV patient with multiple ring enhancing lesions. It can be tuberculosis, it can be toxoplasmosis, it can be brain abscess, it can be NCC, primary CNS lymphoma. So there are multiple different etiologies for multiple ring enhancing lesions in a HIV patient. So non-HIV patients present with diarrhea, as we know, but in AIDS patients, patients with AIDS, most common presentation is diarrhea with wasting syndrome, and there can be keratoconjunctivitis, there can be disseminated disease, there can be hepatitis, there can be myositis, sinusitis, there can be isolated kidney and urogenital infection also, there can be ascites, cholangitis. So you name any syndrome, this microsporidosis in these patients can cause any syndrome in these patients and can be asymptomatic also. So diagnosis, because renal involvement, the shedding of spores in urine is common in all species of microsporidia that disseminate. Urine specimens should be obtained whenever the diagnosis of microsporidosis is considered. So this was a new point, new learning for us. So when we are suspecting disseminated microsporidiosis, definitely urine examination for microsporia has to be ordered and have to be carefully checked. Because to know whether it is disseminated disease or not, there is a small distinction, because this encephalotoxin genera are sensitive to albendazole. The drug of choice for this encephalotoxin genera are albendazole, whereas enterocytoxin are resistant to albendazole. So if stool examination is negative in the setting of chronic diarrhea, and these organisms generally reside in the lower small bowel, is what it is mentioned in the ileum and jejunum. So an endoscopy should be performed to identify these pathogens if diarrheal examination is not confirmative. So the most common pathogen is enterocytoxin bionici, and albendazole is a drug of choice for all the CNS causing disseminated disease genus. And for ocular microsporidosis, fumagillin is advised but is not available. And the most effective prophylaxis is a restoration of immune function in immunocompromised host. So as it can be asymptomatic also, restoration of immune function will lead to resolution of diarrhea. So that is the first case. Second case, he is a 15-year-old gentleman from Hyderabad. He came with chief complaints of headache for 3 days and right arm and leg weakness for 12 hours before admission. So there was only 2 complaints: headache for 3 days and right upper limb and lower limb weakness. And coming to history of present illness, this headache is generalized headache, and which was continuous and on a scale of 6 to 10. And this right arm and right leg weakness is acute in onset 12 hours prior to admission, and it's progressive. And on the day of admission, he fell from the bed, and that is the reason the attendants have brought him to the hospital. And so that mild altered sensorium was there. There is no history of fever, no history of cough, no history of headache, vomiting, or trauma, no history of seizures. Past history: the patient of HIV for last 15 years, he's on TLE regimen from elsewhere, and his recent CD4 is 350 and viral load is less than 100 copies. No other comorbids. And recently he had zoster ophthalmicus involving the left V1 dermatome some 2 months prior to the present presentation, and he was treated elsewhere before coming to us. No addictions, he is a single person. No prior surgeries. So on examination, he was conscious, little drowsy but arousable. He was aphasic. He had fever, and the prior zoster ophthalmicus healed scar was present, and right upper limb, lower limb weakness was present with power of 2/5. There was mild neck stiffness. So this is the initial picture of this patient. So as you can see, the left V1 dermatome, the old healed zoster scar is present here. So with this initial chief complaints and history and examination, we thought it's a case of maybe acute meningoencephalitis. He recently had a zoster ophthalmicus. So it can be zoster meningoencephalitis too in this patient, as is a case of HIV patient, or it can be some commute-acquired bacterial meningoencephalitis, or it can be the history is too short to suspect TB and cryptococcus, but we also kept differentials as TB and cryptococcus in this patient. Or he is having right upper lobe, lower right arm and right leg weakness, or are we dealing with some intracranial space occupying lesion in this patient, like brain abscess or primary CNS lymphoma. So MRI brain with contrast was done. Sorry, I could not show the images. So this, which reported areas of diffusion restriction noted in the left sylvian fissure with MCA territory stroke. Actually, this patient had stroke in the MCA territory, left MCA territory, which led to right upper limb, lower limb weakness and right facial nerve weakness. So his other investigations are normal. So we went ahead and did CSF analysis, as the fever was there, ultrasensory is there, neck stiffness is there. So along with stroke, it can be some meningoencephalitis this patient. So we have done CSF analysis, so which reported lymphocytic predominant CSF with initial stains and cryptocal antigen being negative. And the meningoencephalitis panel reported zoster virus. So as expected, we thought as he recently had zoster ophthalmicus, which has led to this zoster encephalitis and stroke. So finally, it's a case of acute meningoencephalitis caused by varicella zoster virus and associated vasculitis and stroke. And this varicella is also notorious. Patients who have recovered from zoster, especially facial zoster, they are at risk of developing stroke within 3 months. The patient ART was changed to dolutegravir based regimen, and patient has received acyclovir for 2 weeks. This very old study which reported increased incidence of stroke following zoster ophthalmicus. So which was published in CAD in 10 years back. So they have compared patients who had episode of zoster and patients who did not have episode of zoster. So patient who had episode of zoster, particularly zoster ophthalmicus, there is a threefold increased risk of stroke 5 to 12 weeks after the episode of zoster. So like in our patient, exactly 8 weeks after the zoster ophthalmicus, he has developed a stroke, which led to a lot of morbidity in this patient. So a few take-home points. CNS opportunistic infections in patients with HIV are life-threatening and have varied presentations and many etiologies, as we discussed, and all efforts should be made to identify the pathogen whenever it is possible. And vaccine preventable diseases like zoster in our second case. And we also had a patient of varicella, a 50-year-old patient developing varicella, HIV patient developed varicella with ARDS, and flu, pneumococcal pneumonia, and invasive pneumococcal disease. So there are various vaccine preventable diseases, and all these patients who are virologically suppressed based on simplified ART are being prone to many diseases which is causing lot of morbidity along with metabolic syndrome, as Dr. Santosh discussed. These vaccine preventable diseases are also a major burden in these patients of HIV who are virologically suppressed. Thank you for your attention.
Thank you, sir, for your very two interesting cases. We had today two talks. The first talk was from Dr. Santosh, sir. So, sir has very elaborately explained us about the future of ART treatment actually. So, sir has explained us about doravirine, lenacapavir, doravirine plus islatravir, and lenacapavir treatment, and also cabotegravir and gilpirine. So in this short presentation, he has shared the overall spectrum of HIV treatment that is going to come. So thank you very much, sir. And Dr. Ravi has presented very two nice cases. So now we can, sir, can we go now to the questions, sir, if they have asked?
Sure.
Yeah, yes, sir. So we'll take one by one. So the first question I'll answer. So is lenacapavir available in India? So not yet, sir. Uh, so few Indian companies might be working on it, but it is not available so far in India. The second question is from Dr. Shakil Shirsat. Is dual therapy approved now for ART naive patients? So yes, sir. So dolutegravir lamivudine is approved for treatment naive patients. Now we come to the next question, which is asked: was stool microscopy done in case one? This is for Dr. Ravi. So,
Yes. Yeah, so it was done, but we could not find any microsporia in the stool.
Yes, sir. And this question, the next question I'll ask to Dr. Santosh. So basically, this question has come from Dr. P. Umarji about the management of HIV in pregnancy and lactation. So you can share the management and what protocol you follow.
Yeah, in HIV, in pregnancy and lactation, the regimes are more or less the same, just like any other patients which we see. So previously, probably 3 years or 4 years back, we had good data in dolutegravir space. At that time, because of lack of data in bictegravir space, they actually told you prefer DTG in pregnancy and lactation. But probably in the last 3 years, we have good data which is backing up for bictegravir as well. So HIV in pregnancy and lactation, the regimes are more or less same like a normal patient. There's no change in regime in respect of pregnancy or lactation.
Yes, sir. And sir, which is the preferred treatment for patients with HIV in pregnancy?
See, for pregnancy or normal patient, the standard 3 drugs. So I generally go with TAF, FTC, and DTG as the preferred because with the TDF, we generally see bone mineral density loss and the renal toxicity. To keep that component less, we try to balance with TAF, FTC, and DTG. That's the preferred combination which we start up.
Right, sir. Right, sir. And this question I'll ask to Dr. Santosh also, sir. In which patients you will use doravirine plus the FDCs which are available combination?
Right.
Your insights, basically.
Yeah, that's a good question. So, see, doravirine, unlike our instis or the DTG based regimes, it may not be taking a space as a blanket thing like instis or so. Definitely the backbone is same. Use it either TAF 50C or TDF 3TC. So we are actually playing with the third drug. Either you're playing the third drug with DTG, or you're playing the third drug with darnavir, ritonavir, or you're playing with doravirine. So probably we won't prefer darnavir, ritonavir in the initial setting. We would reserve it because it's a good high genetic barrier resistant. We would probably reserve it in a resistant. So now comes the question between doravirine versus DTG. So DTG, the good points are no drug-drug interactions, good safety profile. Only issue where we are worried is about the weight gain. If my patient is obese and if they're gaining a lot of weight when they're put on DTG, in the background where the cholesterol, the lipid profile is not good, where atherosclerotic cardiovascular events are high, so in that patients where I can't use DTG to bypass all these adverse effects, then I would probably prefer doravirine.
Right, sir. Right, sir. So I think, sir, we have taken all the questions for today, and so this was a very nice webinar on the latest advances in HIV management and two very interesting cases. So I think we'll close here today because I can't see more questions. I'll just check. So yeah, there are no questions now. So from NQ's side, I wish to thank both of you for sharing the valuable insights and also the case presentations, which I'm sure will be helping for the audience to enlighten them about the HIV treatment. So thank you very much, sir. I think we can close here.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Santosh. Thank you, Dr. Ravi.
Thank you.
Thank you, Dr. Ketan.
Yes, thank you, sir. Thank you.
Yeah. Thank you, Nandakishore. Thank you, Tushar.